Hello everyone. Welcome back to the series of lectures in gastroenterology. In the last session, we had discussed about inflammatory bowel disease. In today's class, we will be learning about another very common disorder, which is your irritable bowel syndrome or your IBS. So let's begin. So what exactly is this irritable bowel syndrome? Irritable bowel syndrome is basically defined as a functional bowel disorder which is characterized by abdominal pain, discomfort, altered bowel habits in the absence of structural abnormalities. So, this is basically a functional bowel disorder which is characterized by abdominal pain or discomfort. It can be characterized by altered bowel habits in the absence of a structural abnormality. So, there is no problem as such with the GI tract. There is no anatomical or pathological problem, but they do have symptoms of abdominal discomfort and altered bowel habits. So this is a functional bowel disorder. The criteria which is used to diagnose irritable bowel syndrome is called as your Rome 4 criteria. So this basically states that recurrent abdominal pain, at least one episode per week in the past 3 months. So there should be recurrent abdominal pain of at least one episode per week in the past 3 months with more than 2 of the following. What are the following? That includes pain which is associated with defecation. Associated with defecation. So pain that is associated with defecation. Then there is a change in the frequency of the stool. There is a change in the frequency of the stools. Third, there is a change in the consistency of the stool. Okay, so this is your Rome 4 criteria for the diagnosis of IBS. So what does the Rome 4 criteria state? It states that there is recurrent abdominal pain of at least one episode per week in the past 3 months with at least 2 of the criteria. That is, the pain is associated with defecation and there is a change in the frequency of the stool and there is a change in the consistency of the stool. Okay, so this is your Rome 4 criteria. Now let us understand the classification of IBS. Let us understand the classification of IBS. So according to the classification of IBS, IBS can be classified as IBS-D, which is your diarrhea predominant subtype. So IBS-D is your diarrhea predominant subtype. Then you have your IBS-C, which is your constipation predominant subtype. This is your constipation predominant subtype. Then you have your IBS-M, which is a mixed type. Okay. So you have IBS-D, which is diarrhea predominant, IBS-C, which is constipation predominant, and IBS-M, which is your mixed type. Now let us look at the clinical features. So the clinical features are predominantly gastrointestinal. Okay, so they are predominantly gastrointestinal. So most important symptom is your abdominal pain. So this abdominal pain can be diffuse or it can be localized. Right, so sometimes it can be in the epigastric region or in the periumbilical region. It may mimic a GERD or a peptic ulcer disease. Okay, sometimes it can be in the right lower quadrant, sometimes it can be the left lower quadrant. So the pain can be anywhere or it can be diffuse. Okay, so this pain is usually associated with a lot of bloating. So most of the patients complain of pain which is associated with a lot of bloating. Okay, and it may be associated with flatus. Then alteration in bowel habits. So there can be a history of alteration in bowel habits in the form of constipation, in the form of diarrhea or constipation alternating with diarrhea. Okay. Then flatulence, which is because of gas formation in the abdomen. Then many of the patients, up to 30% of the patients can have upper GI symptoms in the form of dyspepsia. Postprandial fullness. Okay, and this type of dyspepsia is usually a functional dyspepsia. What is the meaning of functional? That means that we have not found an underlying organic cause. If you do an upper GI endoscopy for these patients, you do not find a cause. There is no evidence of GERD, there is no evidence of peptic ulcer disease. So this is about your main GI symptoms of irritable bowel syndrome. Okay, and always remember that IBS is usually not associated with bleeding per rectum. Okay, so that it is not associated with hematochezia, because if there is hematochezia, then you will have to rule out local causes such as fistula or fissure in ano, right, or hemorrhoids. So IBS is never associated with passage of frank blood per rectum. If there is passage of frank blood per rectum, you have to rule out local causes. Also, if there is bleeding per rectum, then you have to consider more sinister causes like your inflammatory bowel disease or the presence of some malignancy. Okay, and IBS generally is a disorder of young individuals. It is a disorder of young individuals. Okay, so IBS is basically a diagnosis of exclusion. It is basically a diagnosis of exclusion. Now, what are the other clinical features that you can have? Very, very importantly, once we look at the pathogenesis of IBS, you will understand that irritable bowel syndrome is basically a lot to do with the gut-brain axis, what we call as the gut-brain axis. So many of these patients actually have some underlying psychological issues like anxiety or history of panic attacks or depression or mood disorders. Okay, so very, very importantly, you have to look at the psychosocial issues that are found in many of these patients with irritable bowel syndrome. Okay, fine. Now let us understand the pathophysiology of IBS. So IBS is basically a multifactorial disease, right? So most importantly, first point is that it is associated with motility abnormalities. For reasons unknown, there are a lot of motility disturbances in these patients with irritable bowel syndrome. So what happens is that sometimes there can be a decreased motility. If there is a decreased motility, there can be constipation. Sometimes there is an increased motility, especially in your postprandial states, which results in diarrhea. That is the reason why you can have alternating constipation and diarrhea. So you can have alternating constipation and diarrhea. The second hypothesis is that there is some leaky gut and there is some dysbiosis. Dysbiosis basically means that there is an alteration in the gut flora. There is an alteration of your gut flora. Okay, there is some alteration of your gut flora, and many a times, in fact, IBS is also found to be post-infectious in nature. It is found to be post-infectious in nature. Another post-infectious condition which we had studied was your post-infectious sprue, right? Your post-infectious tropical sprue. Similarly, this IBS is also considered to be sometimes post-infectious in nature. Infections with Giardia, infections with Campylobacter, all of these can trigger irritable bowel in certain patients. So in these kind of patients, after an infection, there can be an alteration with the normal gut flora. So because of this normal gut flora alteration, there is a dysbiosis. There is a dysbiosis and the gut becomes leaky. And since the gut becomes leaky, they can have episodes of diarrhea as well. Then, visceral hypersensitivity. So, like I said, many of these patients with irritable bowel syndrome have some underlying psychological issues, right? So, this is a lot to do with what we call as the gut-brain axis. So, many of these patients actually have a lot of visceral hypersensitivity as well. That means that just a plain distension of the stomach in your postprandial state, so just a plain distension of the stomach in your postprandial state can be recognized by the body as a pain stimulus and it can cause pain. So this is your visceral hypersensitivity. Okay. Then we have looked at the psychological causes like anxiety, panic, depression, somatization disorders. Sometimes genetic factors are also present, like for example your SERT polymorphisms. Okay. Then brain-gut interaction we have already looked at. Sometimes an autonomic dysfunction or HPA axis dysfunction can also be associated with IBS. So sometimes an autonomic dysfunction or an HPA axis dysfunction can also be associated with IBS. So another very important factor which has been implicated is your bile acid malabsorption. So many of these conditions where there is a post-infectious cause which has been found. In your post-infectious cause, many of these infections can cause an alteration in the gut motility. It can cause a bile acid malabsorption where there can be damage to the ileum. There can be interruption in your enterohepatic circulation. There is an interruption in your enterohepatic circulation of the bile. If there is a disruption to the enterohepatic circulation of the bile, then this can result in malabsorption. And finally leading to your IBS diarrhea type of disease. Okay. So these are the various hypotheses which have been put forth for your pathophysiology of IBS. So most often we have not found any definitive cause, but most often there is an underlying psychological disorder and there is an alteration in your gut microbiota in your post-infectious diseases, or there can be visceral hypersensitivity, motility abnormalities, all of which contribute to this group of disorders that we call as irritable bowel syndrome. Okay, fine. So what have we learned till now? We are learning about irritable bowel syndrome. We have learned that this can be characterized by episodes of functional dyspepsia, functional abdominal pain, functional diarrhea or constipation where we have not found any actual pathological problem in your GI tract. Okay, and the pathophysiology and clinical features we have understood. Now let us move forward. So what is your approach to the diagnosis of irritable bowel syndrome? So to diagnose IBS, it is a disorder by which you obtain, cut the last line. So this is a diagnosis of exclusion. Okay. So irritable bowel syndrome is basically a diagnosis of exclusion. So to diagnose IBS, you really have to evaluate the patient completely before labeling him as IBS. So what are those symptoms where you will say that IBS is maybe not a possible underlying problem? So what are those conditions where you will say that IBS is maybe not the possible underlying problem? So if these first symptoms basically appear in old age, then it is less likely that it is going to be IBS and you better evaluate the patient. Then presence of blood in stools, that we have already seen, presence of blood in stools. Then presence of nocturnal diarrhea. Is against IBS. Then persistent diarrhea even after fasting for 48 hours. So persistent diarrhea even after fasting for 48 hours. Then that means that it is not an irritable bowel syndrome. Okay. Now let us look at some of the differential diagnosis for IBS. Then firstly, pain, depending upon the location of the pain. If this is an epigastric pain, or a periumbilical pain. Then what will you think of? You will think of peptic ulcer disease. In your periumbilical, you can think of pancreatitis, right? Sometimes if they have postprandial fullness, what will you think of? You will think of mesenteric ischemia. Okay. So in your lower abdomen, if you have pain, so if there is pain in the lower abdomen, then what will you think of? You can think of pelvic inflammatory disease. You can think of inflammatory bowel disease. You can think of appendicitis and so on. So this is a huge list of differentials for abdominal pain. But you do a good physical examination and you find that there is no tenderness, there is no distension of the abdomen, then you go on forth and keep one of the differential diagnoses as IBS. Okay. But very, very importantly, next you look at your next symptom, which is your diarrhea. So in diarrhea, if the patient is presenting with diarrhea, you have to take a good history of travel, a good history of medications, because many a times the diarrhea is because of medication induced, or it can be because of infections, especially in the tropical countries, tropical infections like Giardia, Campylobacter, or your traveler's diarrhea and so on, right? If you are suspecting malabsorption, if this has been a chronic form of diarrhea which has been there for more than 6 weeks, then you can think of malabsorption, you have to think of malignancies, you have to think of HIV infection as well in your chronic diarrheas. Okay. Amongst the malabsorption syndromes, very importantly, the disease of IBS mimicker is your small intestinal bacterial overgrowth, right? So your IBS mimicker is your small intestinal bacterial overgrowth, because SIBO, as we had learned in our disorders of malabsorption, that this can also present with abdominal pain and bloating, right? So how will you differentiate IBS from SIBO? This will have a hydrogen breath test positivity. This will have a hydrogen breath test positivity. Your SIBO will have a hydrogen breath test positivity, but IBS will not have, right? Because it's a functional disorder. Okay. Then we will look at constipation. When it comes to constipation in the elderly, you definitely have to think of malignancies. You have to think of malignancies. In younger age group, even endocrinopathies like hypothyroidism, right? Endocrinopathies like hypothyroidism can also cause constipation. So before you just wash off or rub off the diagnosis as a functional disorder, always think of the underlying differential diagnosis. Fine? Then we move on to the evaluation. What are the tests that you want to do to evaluate a person before labeling them as irritable bowel syndrome? So you want to do a CBC, yes, because if there is presence of anemia, if there is presence of vitamin B12 deficiency, then you have to think of malabsorptions, right? Chronic disorders with malabsorption can cause IDA or B12 deficiency. Then you want to do a stool examination, yes, you do a stool for ova or parasites to rule out infective causes. You do a stool for ova and parasites to rule out infective causes. Now, if there is history of blood in stools, or if there is doubt of your inflammatory bowel disease, you can do your stool for calprotectin as well. Stool for calprotectin is done for your inflammatory bowel disease. Then you definitely go ahead and do a sigmoidoscopy and you see for the presence of any pathological change, because IBS is a functional disorder, your sigmoidoscopy will be normal. But if this is due to infections, if this is due to inflammatory bowel disease, you can find the presence of ulcers. If there is a malignancy sitting there, you can find it on your sigmoidoscope. Then in some patients, you may have to give a lactose-free diet trial. Why? Because lactase deficiency also can present with bloating, diarrhea, abdominal pain. So in certain patients, if you are suspecting a lactose intolerance, you can give a trial of lactose-free diet as well. Then your hydrogen breath test is done to rule out small intestinal bacterial overgrowth. In patients who are presenting with predominantly dyspeptic symptoms like your nausea, postprandial fullness or vomiting, then you may have to do an upper GI endoscopy to rule out any local causes of GERD or peptic ulcer disease. Okay. So the entire point of this exercise is to emphasize the point that irritable bowel syndrome is a diagnosis of exclusion. So before you go ahead and diagnose someone as IBS, evaluate them thoroughly. Now let us move on to the management of IBS. So the first and the most important part of the management of IBS involves patient counseling. Why? Because many of these patients have psychological issues and patient counseling becomes very important. Also because they are having chronic symptoms, they will have a lot of irritability and they may have a lot of anxiety with respect to their disease itself. So patient counseling, making them understand that this is a disorder that can be managed with a lot of lifestyle measures is very important. Then you will have to counsel them very importantly about the diet. So, what is the type of diet that we advise the patient? This is called as a low FODMAP diet. So, this is called as a low FODMAP diet. So, what does FODMAP stands for? FODMAP stands for fermentable oligosaccharide, disaccharide, monosaccharide and polyols. Okay. So, there is a huge list of food items which are these FODMAPs, which have these FODMAPs. And why we say that we should avoid this? These group of food items have to be avoided because they can trigger the symptoms of IBS. So, they can trigger the symptoms of IBS. They can cause a lot of bloating and dyspeptic symptoms. So, certain examples of these foods are, for example, legumes. Or for example, you avoid even your high fructose containing foods. Okay. So, what we advise is to follow a low FODMAP diet. Now, apart from this, what other counseling do you want to do? So, the most important counseling that you want to do is that you have to advise the patient about anxiety reduction techniques. A good sleep hygiene and adequate exercise. You have to counsel them about all of your lifestyle measures as well. Now, let us look at the drugs which are used per se in the management of IBS. Now, let us look at the drugs which are used per se in the management of IBS. Now, let us look at the drugs which are used in the management of IBS. Okay. So, the first group of drugs is your stool bulking agents. So, what are the stool bulking agents? They are basically your high fiber agents. Okay. So, your bran, isabgol, husk and so on. So, these are basically stool bulking agents. So, they ensure that the stools are formed appropriately and they prevent the dehydration of the stool. And thereby they help in relieving constipation. Okay. In certain proportion of individuals with IBS diarrhea phenotype. So, in certain proportion of individuals with IBS diarrhea phenotype also stool bulking agents can help. The reason being is that this also helps sometime in decreasing the motility. It helps sometime to increase the retention of the stools, enhance the bacterial action on the stools, and it helps in decreasing the gut motility at times as well. That's the reason why stool bulking agents can help in the IBS-C phenotype as well as the IBS-D phenotype. Then the next group of agents that we can use in the management of IBS is your antispasmodics. So, the next group of agents that we use is your antispasmodics, which help in relieving your abdominal pain. So, predominantly what we use is your anticholinergic agents, and they inhibit the gastrocolic reflux, thereby reducing the abdominal pain, especially in the postprandial state. The newer drug that we use now is an anticolic agent that we called as acotamide. Okay. The new anticolic agent, The new anticholinergic agent that we are using is called as your acotamide. Okay. This is used in functional dyspepsia. Okay. The main side effects of anticholinergic agents that you have to be aware of is your dryness of mouth, dryness of secretions. They can cause a lot of blurring of vision. Apart from that, they can cause a lot of drowsiness as well. And that's the reason why in elderly individuals you have to be very careful with the use of anticholinergics. Fine. Then the next group of drug that we use is predominantly your antidiarrheals. So, the main group that we use is those which basically decrease the gut motility. So, for example, loperamide. right? So loperamide is a drug which basically decreases your gut motility. Then we use antidepressants, which includes your tricyclic antidepressants or SSRI, because many of these patients have an underlying psychological problem. So controlling the anxiety, controlling the underlying psychological problem causes a lot of improvement in your IBS symptoms. The next group of drugs is your serotonin receptor modifiers or serotonin receptor modulators, which predominantly act on the 5-HT3 and 4 receptors which are present in the gut. The serotonin receptor 5-HT3 or 5-HT4 which is present in the gut. So, the 5-HT3 and 4 inhibitors, the example or the prototype drug is your prucalopride, which is predominantly used in your IBS-C phenotype. It increases the secretion, it's your IBS-C phenotype. Okay. Then secretagogues are basically those which increase the intestinal secretion, right? They increase the intestinal chloride content, they act on the ion channels in your intestine and they increase the intestinal secretions, they increase the water and chloride content in your intestinal secretions, and hence they are again used in your IBS-C. Okay. So, the prototype drug is your lubiprostone, it is your lubiprostone, and the other drug is your linaclotide. Linaclotide basically acts on guanylate cyclase enzyme in the intestine, which again increases the secretion. So, they are their secretagogues. Okay. The last way of treatment is the modulation of gut flora. We have understood that there is a lot of gut dysbiosis which is happening, and the good flora are usually replaced by other flora which causes an alteration in the bowel habits. So, treatment with antibiotics like rifaximin, 400 mg BD for 14 days has been shown to be effective in the management of IBS. Okay. Apart from this, there have been trials of probiotics and prebiotics which have not been very useful. So, this is about the various group of drugs which are used in the management of IBS. So, the management of IBS should be a multi-pronged approach. Very, very importantly, you counsel them about lifestyle measures, you counsel them about your diet changes. Then these are the group of drugs that can be used. Now, let us look at it more in detail. Right? So, for diarrhea, what are the drugs that can be used? We can use loperamide, which decreases the intestinal motility. Apart from that, sometimes cholestyramine is also used. Another drug which is used is your allocetron, right? So, the allocetron is another drug which is used, which is very similar to your ondansetron. So, the next drug is your allocetron. So, what is the mechanism of action of allocetron? Allocetron is a 5-HT3 inhibitor. It is a 5-HT3 inhibitor and this will decrease the motility and improve the visceral hypersensitivity as well. So, drugs used in constipation, we have your husk methyl cellulose, lactulose syrup, which are all stool softeners which help in bulking of the stool, and lactulose is your stool softener. Right? Then we have your lubiprostol and linaclotide, which are your secretagogues which we have just learnt. Then you have your prucalopride, which is your serotonin modulator of the gut. Then abdominal pain, you can use smooth muscle relaxants, and treating your underlying anxiety or depression can also help improve the abdominal pain. So, SSRIs and TCAs are also used in the management of abdominal pain in your irritable bowel syndrome. Then for gas and bloating, sometimes rifaximin helps, sometimes low FODMAP diet will help, sometimes probiotics will help. Okay. So, this is about the management of irritable bowel syndrome. So, with this we have come to the end of our session on IBS. Thank you.